Thank you very much for joining this session. I'm really honored that you take your time and you want to listen and discuss about the anatomy of disinfection failure. However, before we'll start talking about anatomy, let's define what the challenge is and who is our biggest enemy in this challenge. I think none of us really have doubts that biggest challenge is really related with hospital-acquired infections or infections at all. And let's have a look on the numbers. And I think we all need to admit that most likely those numbers are really underestimated. However, hospital-acquired infections are related with huge costs. It is estimated that just for NHS in England, those costs are roughly more than £2 billion per year. But hospital-acquired infections are also related with a pretty high mortality rates. Yeah, more than 20,000 deaths per year just in UK. When we are looking on the data from US, those data are even more impressive or terrifying, to be very frank, because in terms of financial impact, we are talking about even 45 billion US dollars per year. So that's the reason why we also need to think about our biggest enemy. And our biggest enemy in this challenge is antimicrobial resistance and infections caused by resistant organisms or organisms which are heavy to or difficult to inactivate. But that's also the reason that antimicrobial resistance and infections caused by resistant bugs seems to be most pressing threat for a global healthcare. According to Global Antibiotic Resistance Surveillance Report, as per definition from this report, antimicrobial resistance occurs when pathogens do not longer respond to antimicrobial treatments, which includes antibiotics, antiseptics, also disinfectants. And as a consequence, it will lead to, first of all, longer treatments, second of all, increased cost of the treatment, and what is most important, to higher mortality rates. Obviously, we need to bear in mind that resistance, as per definition, is irreversible process. When we are looking on the numbers related with antimicrobial resistance, we can clearly see, and that's the estimation, yeah, that in 2025, about 10 million deaths was caused by resistant pathogens. And this rate will increase very significantly. Estimation is that between 2025 and 2050, this rate will increase to even 39 million per year. However, that's obviously the most terrifying thing, but we cannot forget obviously about costs. Cost impact, not only direct cost for a treatment, not only direct cost for a healthcare system, which might even achieve $1 trillion US dollars, but also about huge GDP losses, which can even hit more than $3 trillion US dollars. That's the reason why really global health community consider that we are entering into post-antibiotic era. So it seems that history is making circle, yeah? We've already been here in the pre-antibiotic era, where infections was causing a lot of deaths. And then in 1929, Fleming discovered revolutionary drug, antibiotics. And then we've been really in the golden age that we've been really able to treat majority of infections. And suddenly, drugs which been revolutionary, efficacy of those drugs are critically declining. That's why I really believe history is making circle, and it seems that we are entering again into this era. That's the reason why WHO as well as CDC define multi-drug resistant organisms as one of priority pathogens. Obviously, they are not the only ones, but one of the priority pathogens. But why it really matters, yeah? It really matters because all type of pathogens, all type of microbes can be easily transmitted, and by transmission can cause at the end infection. And here, nobody should have doubts that environmental contamination plays a pivotal role. High-touch surfaces, medical devices, shared equipment. All those devices, equipment, surfaces can facilitate spread of microbes, which can persist on the surface for even months, like, let's take as an example, C. diff spores, which can persist on the surface even a few months. Because of all those things, we need to remember that robust disinfection protocols are necessary. Because we are facing with a strong and significant enemy. I've mentioned about multi-drug resistant organisms like methicillin resistant Staphylococcus, carbapenem resistant Enterobacteriaceae, but that's not all. Let's not forget about spore-forming bacteria. However, most important thing is that all of them can represent significant risk. All of them can cause dangerous infections, very difficult to be treated, or right now can happen that we've not been even able to treat those infections. That's why prevention is so critical. And unsuccessful prevention and transmission control can only lead to spread of those microbes. However, transmission of microbes, especially resistant organisms, is heavily influenced by environmental and procedural pressures, and both of them can be effectively treated with right level and right quality of disinfection. However, resistant organisms, resistant pathogens are not only enemy. Our second enemy is a biofilm. I'm pretty sure that all of you are familiar with this picture. All of you are familiar with the biofilm concept, yeah? But just to be sure that we are all on the same page. Biofilm, as per definition, is a community of microorganisms that, first of all, can attach to the surface. Second of all, is covered by, let's say, slimy layer, which is extracellular polymeric matrix. And that's the reason why bacteria which are inside of the biofilm are very heavy to be touched by chemicals, by physical factors, by drugs. That's also the reason why behavior of biofilm is way different from free-floating planktonic cells. And biofilms, or fact that biofilms are covered with this matrix, with this external structure, is giving serious implications. So first and foremost, to treat biofilm infections, you need to use way higher concentrations of medicines, way higher concentrations of antibiotics. On top of this, biofilms are also very difficult to be inactivated by disinfection, because this protective layer pretty often is also a huge barrier for chemical or physical agents, which are pretty often used as a disinfecting agents. It was proven in one of the publications, that was publication about endoscope-associated outbreak of carbapenemase producing Klebsiella pneumonia. And it was very clearly proven in this paper that, on the one hand, concentration of active substance which need to be used to inactivate, to kill those microbes, need to be way higher if we are discussing biofilm structures in comparison to standard planktonic cells, which as a consequence can lead to unsuccessful disinfection, because pretty often concentrations of actives which are effective against biofilms are higher in comparison with the standard concentrations which are routinely used in a daily life. Unfortunately, so far in Europe, we do not have standardized tests against biofilms, and I had the privilege to have a presentation about standardization in efficacy testing here last year. However, we have standardized and approved methodologies from US, so methodology approved by EPA, which is relying on biofilm generated in CDC reactor is one of those methodologies. And without going into details of the methodology, it is really about growing biofilm on the carrier. Later on, this carrier is put into the solution of the disinfectant, and efficacy or log reduction is tested. And here I would like to share with you some interesting data. This is ongoing work, so I'm really presenting you preliminary data. But what we can clearly see that, first of all, not all actives are equally effective against biofilms. So let's look on standard wet biofilms. We can clearly see that, for instance, ready-to-use stabilized chlorine dioxide in just 200 ppm concentration is able to achieve more than 10 or around 10 log reduction, whereas standard concentration or concentration which is routinely used in commercially available products of sodium hypochlorite, known as a bleach, do not have any efficacy. When we are looking into comparison against in a 2-minute contact time, when we are looking or when we are comparing also stabilized ready-to-use chlorine dioxide against peracetic acid, also in relatively high or standard concentration of 2,800 ppm, we can also clearly see that PAA works better, but still not as good as chlorine dioxide. According EPA, by the way, according EPA methodology, according approved protocol, to be able in US to claim efficacy against biofilm, at least 6 log of reduction is needed. So according to this definition, according to this requirement, even PAA would not be able to claim this biofilm efficacy. But interesting thing is also dry biofilms. And here, in case of dry biofilms, we can clearly see that stabilized chlorine dioxide, ready-to-use stabilized chlorine dioxide in just 200 ppm concentration can also achieve pretty high log reduction, almost 5 log reduction, whereas sodium hypochlorite do not show any reduction. This dry biofilm methodology is not yet approved. That's the work under development. So we don't know what will be the limits which EPA will approve for this. However, I just want to show you that different actives can show different efficacy level, but at the end, it's not only about actives. At the end, it's also about particular formulation of products. So at the end, why disinfection really matters, yeah? We are all aware that pathogens can spread by colonized patients, by staff, and they can persist, they can stay on mainly on high-touch surfaces, on the equipment, shared equipment, on medical devices for days, weeks, or even months in case of spore-forming bacteria. C. diff is a great example here. And multiple reviews and guidance will really prove that role of environmental disinfection is a key pillar in preventing resistant organism spread, but also in prevention as a consequence is a key pillar in prevention of hospital-acquired infections or infections at all. And disinfection really matters because disinfection simply works. However, we need to bear in mind one thing. We need to use right products, we need to apply products properly, we need to follow instructions, we need to follow recommendations, and we need to pay attention to a couple of important things. First and foremost, products need to be tested according to standardized efficacy report and show passing results against those standardized efficacy or efficacy standards. And only if we'll be using such products and those products will be used properly, we'll have a right program to prevent or to have a successful disinfection. Because studies consistently show that improved disinfection protocols for devices, for medical devices, for shared equipment, for high-touch areas can significantly reduce cross-transmission risk and, as a consequence, risk of infection. And why disinfection simply works? It is mainly related with a mode of action. On this video, you can see mode of action of stabilized, ready-to-use chlorine dioxide. And the beauty of disinfection is, or majority of active substances which are used in disinfectants, beauty is that disinfectants acting broadly and they are targeting or hitting multiple targets in the same time. So we can say that disinfectants generally are not selective agents, unlike antibiotics, for instance. So they are interacting with proteins, with cell membranes, with nucleic acids, with mitochondria, and they are causing their damage, which is visualized here. So at the end, bacterial cell, pathogen cell, as a consequence, is simply destroyed. In case of stabilized chlorine dioxide, there is one additional benefit, because this molecule, after action, after interaction with microbes, will break down to salt and water. So that's the additional advantage. But because of such mode of action, disinfection, in terms of principle, if applied properly, because of such mode of action, disinfection is reliable defense. However, if applied properly, we need to bear in mind that there might be some variability in disinfection quality, but there might be also some variability in product performance or quality of product composition. So suboptimal practices such as inadequate contact times, missed surfaces, incorrect dilutions, products which are used inadequately to the application will significantly reduce efficacy, and they, as a consequence, such suboptimal practices can lead to adaptation to some actives. And just to show you some example. So on the one hand, it's about way of application. On the other hand, it's about proper formulation. Here you can see example of commercially available product. And as you can see, I hope you all can see this video. This product cannot cover surface properly, or surface is not staying wet. Yeah, that's about wettability. So for me, it's very hard to believe that in a real life scenario, such product will be able to give enough efficacy and will be able to significantly contribute into infection reduction. Because surface should really stay wet, we should really have, or microbes should have a chance to be in touch with active substance. In the same time, you have a formulation which shows same efficacy level, and you can see that surface is staying wet. Surface is evenly covered by the liquid. So previous one is commercially available product. This one is a new formulation, newly developed by Arxada. So you can see that not only way of application, not only human error, but also how product is really formulated, and that's not only about active at the end, can lead to some issues. But I've mentioned about adaptation, and that's very interesting thing, adaptation. So potential for the adaptation to chemical compounds has been so far proven for a couple of different active ingredients, and those findings was confirmed by numerous of studies showing that bacteria as well as some yeasts or fungi can adapt to typically used concentration of different actives, like chlorhexidine digluconate, like sodium hypochlorite, etc. However, it was really difficult to quantify risk related with this. However, let's think first what the adaptation is. As per the definition, adaptation is ability or process of adjusting to new environments or conditions. Adaptation should be reversible. And to really quantify risk of this adaptation, Professor Karpiński developed so-called Karpiński Adaptation Index. In the nutshell, this index provides quantitative assessment of the adaptation level or adaptation risk in relation to commercial concentrations of the biostyle active compounds. And in one of his recent papers, he proved or he showed that sodium hypochlorite can achieve very high adaptation index, Karpiński Adaptation Index, so more than one, which suggests that potential for adaptation or risk for adaptation for this particular active is very high. And as a consequence, it can lead to the situation in which, after time, commercially available concentrations, so disinfectant which you are using on a daily basis, will not be effective anymore. And third pillar, aerosols, or disinfectants applied by spraying. Pretty interesting thing, because on the one hand, it can have impact on the quality of disinfection. On the other hand, which is, in my opinion, even more important, can have impact on the health of the healthcare workers, healthcare professionals. So on the one hand, disinfectants applied in a spray form are very convenient. I believe that's the case. They can save a lot of time, and they are giving sort of a feeling that, you know, everything is done right and quickly. However, over the last years, spraying has raised concerns, mainly about the occupational health risk. And in the number of recent studies, significant association between exposure to, in this particular case, bleach apply in a spray form, and poor asthma control, new asthma onsets, chronic destructive pulmonary disease, ocular and nasal symptoms were reported. However, spray exposure is not related only to bleach as an active substance. That's a general risk, and exposure to small-sized droplets, which can be very easily aspirated. Such risk is a case for all type of actives. As a consequence, it can lead to 5-fold higher odds of having higher asthma symptom score. In the same time, other applications like wiping, like mopping, are not causing any significant risk, or they are not related or correlated with any severe respiratory symptoms. Last but not least, something what probably nobody is really thinking about, using trigger spray bottles many times per day can lead to wrist issues due to the repetitive strain. And now coming back to sodium hypochlorite, there is a risk that generally by using sodium hypochlorite, or other way around, sodium hypochlorite have a high potential to create so-called chlorinated organic matter. Why it really matters? Chlorinated organic compounds can cause various significant health risks, like cancer, like endocrine disruption, like immune system suppression. And exposure can occur, among others, through the skin contact, through the drinking water, and obviously severity of effects will always depend on type of compound, so type of chlorinated organic compound, concentration, and duration of exposure. Last but not least, sodium hypochlorite, known as a bleach, can react with organic compounds and create byproducts like chloroform. On top of this, bleach can cause a lot of skin burns and eyes damage, can cause nose and throat irritation, lungs irritation. It was mentioned also on the previous slide that sodium hypochlorite was really associated with a lot of asthma symptoms, or increased number of asthma symptoms. So because of all those concerns, we at Arxada, we are committed to constantly work on innovations to develop safer, better, more efficacious product. And one of our latest developments, we believe, is a game changer. This is ready-to-use stabilized chlorine dioxide, which have a full efficacy spectrum, proven according to latest EN standards for healthcare space. And this product, as well as other products, are available through our partners, which are here. So I can really encourage you to visit a booth of our partner, of Evans Vanadine, to discuss details of this product. However, I also want to let you know, please stay tuned, please observe us, because, as I said, we are committed to develop new products to provide better, safer solutions to the healthcare environment. So new products are coming soon, and one of them will be QuantiCare PFA. So if you want to follow us, please scan this QR code, sign to our newsletter, and you will be informed, obviously, about our latest developments, but also you will get access to our blog, where we are posting, I believe, a lot of interesting content for a healthcare space.